Good afternoon to everyone present
Good
here with us
afternoon to
today.
everyone present over this
Uh,
today.
Today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by your keynote speaker, Doctor, for today's session. With much pleasure and honor, let me welcome our very renowned doctor, Dr. Shujit Ash. Sir is MBBS Diplomat of National Board in Obs and Gynecology, Fellowship in Minimal Access Surgery, Diploma in Gynecology Endoscopy, Senior Consultant in Gynecology and Ops Department at PD Hinduja Hospital, Mumbai. Now, with the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is endometriosis and infertility, a case of hope amidst the hustle. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, sir.
I'm Dr. Astajit, and today we'll be talking about an important topic, infertility, that is endometriosis, and how do you manage fertility. And the highlight will be given supporting with a case that I had come across. So, every time, whenever you have to manage an ovarian disease, it can be puzzling because whenever you come across any ovarian issues, it can be a difficult entity to tackle. You might come across benign cystic disease or endometriosis, PCO malignancy, and any case like this is always challenging when you have to think about fertility and ovarian issues. The presentations can be varied. You might have a mass in abdomen, or most of the times you might have menstrual irregularities, some syndromic change if you have PCO, and fertility issues. To reach the proper diagnosis, you have to ask a proper history all the time, that you find out where what you are supposed to be tackling with and how you will manage it. We all know that endometriosis is currently one of the leading causes for fertility related issues, along with an ovarian or pelvic mass, and can, or most of the times, is associated with abdominal pain. It's a very high prevalent disease currently, and women complain of severe pelvic pain and infertility. Endometriosis, as such, now possesses a significant public health problem. It is one of the leading causes of also gynecological hospitalization in various countries. Managing a case of endometriosis is always a dilemma because you need to tackle the problem. It can happen again, and managing a fertility with endometriosis becomes challenging at every step. So let's give you a background of this case. So what we are managing here is a 35-year-old female who is married since 4 years. She has never conceived yet, though she's trying since the last 3 years. When this patient came to me, she actually was referred to me from outside, from a sort of a tier two city, and she didn't have any papers, but I saw a few reports that she had, and she had been undergoing certain investigations. She was investigated for fertility, only the female was investigated. So the wiser thing would always be also investigate the male partner for the semen analysis. This patient had done some 4, 5 follicular studies. Last was around 9 months back compared to what we saw her. And she was ovulating well, but she did complain of pain in abdomen during periods and even some amount of dyspareunia. She was feeling heavy since the last 3 months, heavy in the abdomen, and the pain had increased in the last 3 months. It was a dull aching pain which was generalized in nature, which aggravated around the periods, but otherwise there was no bowel bladder complaints along with it, no aggravating factors apart from the period part. Pain was relieved on taking certain antispasmodics. There was moderate to heavy bleeding during periods which were painful, and among the history of surgeries, there was only a history of appendectomy. No relevant medical history was associated with this. So, understanding from here, the picture that we get is that this patient is a primary infertility patient, because if you're trying for 12 months and nothing is happening, primary infertility is that is what we define it as. Considering what I had 9 months back, the follicular study sonography that was completely clean. but again done from a very local ultrasound place, so again not very reliable. And she did have a complaint of pain in abdomen and dyspareunia and some heaviness. She always think of endometriosis in some cases like this. So what I had on mind as a picture was primary infertility with some component of endometriosis, obviously in such scenarios. So the primary investigation in such cases always is, again, I repeat, all the fertility and basic investigation, blood investigation for her. And along with that, I also ask for a sonography. So when we did an examination per abdomen, there was no organomegaly. Per speculum examination, things were fine. I took an opportunity and we did a pap smear for her. Per vaginal examination, things were fine. Her EMH was 3.2, which was quite good. 6 months prior, 6 to 9 months prior, what we had seen, the semen analysis was within normal limits. Follicular study, ovulation seen with induction. Now, when we did the sonography for her today, when we saw her, there was a ultrasound which suggested a fibroid and a right-sided ovarian endometriotic cyst. Now, the cyst was completely quite a large one. It was a 7 centimeter into 6 centimeter into 5 centimeter cyst. Considering that she was getting follicular study, this cyst seemed a little large. So it might have been some endometriotic cyst or hemorrhagic cyst because it had some amount of debris which were there. Right ovary was seen separately, left ovary was obscured, and there was a small 2 into 3 centimeter grade 5 fibroid which was almost subserosal. So obviously, this doesn't make much of a difference when you have to plan for fertility. But again, from this picture, step two, when we get an investigation and a sonography done, her AMH was pretty good. So that was a positive thing. But her ultrasound showed an endometriotic cyst, which was quite large. And obviously, the tubo-ovarian anatomy is distorted, considering that there was a mass which was there. And because of the debris, because of the component inside, it was labeled to be endometriotic or hemorrhagic cyst. This was a basic ultrasound picture. You can see the endometriotic cyst quite evident, which was there. And when we decided that, yes, this is something which is there and we needed to plan for a procedure for her because this is a primary infertility, we decided that we'll go in for a laparoscopic myomectomy. So we'll remove that small fibroid and we'll do a right endometriotic cystectomy as well as laparotomy if things are bad. Because when we decide on according to the SRA guidelines, any cyst larger than endometriotic cyst larger than 4 centimeter needs to be operated. We told her that in this scenario, since the cyst is quite large, there might be a need for SOS oophorectomy, but she had denied the consent. So when we plan for the surgery now, I have to go and tackle the endometriotic cyst, and I have to go and manage the fibroid. As we entered, this was the view. We'll have multiple pictures at different level. So when you enter in this, so everything was quite stuck up, which can happen in cases of endometriosis because of bleeding in the peritoneum cavity. So yes, things were stuck up. Extensive adhesions were noted with the tubo-ovarian mass, which was also stuck with omentum along the left fundо-posterior aspect of the uterus. So if you see slowly, we try to dissect. In the third picture, if you see, we could actually see the ovary after quite amount of dissection. And then we dissected and we went into the adhesion and everything. What we found was there was a large hemorrhagic containing ovarian cyst on the left side with hematosalpinx. So the entire tube and ovary was swollen up, but there was no evidence of endometriosis on that side. There was an evidence of ovarian torsion on the fallopian tube with 4 twists. An ovarian cyst was completely detached with the left support of infundibulopelvic pelvic ligament, which was suggestive of ovarian torsion, which was on a chronic origin. So if you see the picture properly, you will see that the ovary is floating in the middle. That's the left ovary. Way down, if you see below the ovary, below my grasper, not the left side, the right side, you will see the ovary, but that had a component of endometriosis, but the left ovary was quite enlarged with the ovarian mass causing torsion around the tube. And that itself was a chronic origin. Probably for the last 6 months, this cyst kept on expanding and expanding, and that separated from the infundibulopelvic ligament. So we had a floating ovary which had undergone torsion around the tube, leading to hematosalpinx and a hemorrhage containing ovarian cyst and a right ovarian endometriotic cyst. Now the dilemma that comes in is that if I remove the ovarian torsion, we have to save the ovary. Do I save the ovary or do I just do an oophorectomy and come out? And if you understand that if the ovary is separated from the IP ligament, the ovary has to be fixed somewhere, right? So the ovariopexy has to be planned out if I'm leaving the ovary, since we are eventually dealing with the case of fertility. So those were the dilemmas that come in when you plan to operate such a case. So when we detorted the ovary, the decision of ovarian cystectomy was taken after draining the ovarian cyst and hematosalpinx was considered. So what we did was we detorted the ovary. We had an large ovarian cyst with the hematosalpinx. We decided to do an ovarian cystectomy. We took a small nick and the cystic fluid was aspirated. There was no chocolate fluid in that. And the unilocular cyst with hemorrhagic fluids with non-uniform, non-papillary cyst wall was seen. There was no solid component, and remaining ovarian tissue after we did this was viable. And when we checked after doing a myomectomy, which we did in the process, the ovary seemed quite good. So we decided to anchor the ovary to the posterior surface of the uterus to prevent further torsion. This was the plan, and this is how we went in. So if you see, that's the ovary. We did a detorsion for the ovary. And as soon as we remove the torsion from the ovary, you can see nicely that the tube also has reduced the congestion and the tube also looks quite healthy. And that was a large cyst. We took a small nick around the ovary and we removed the fluid that came in. The cyst wall was also separated nicely, hemorrhagic fluid that came out. And then in the last picture, you see that the entire cyst wall was removed and the ovary looks quite good in that situation. This, again, remember, this is an ovary now, which is free of the cyst wall and the cyst fluid, and it's hanging just by the tube. There is no IP ligament support for this. This was a myomectomy that we did. So if you see, that's the fibroid which was there. We infiltrated, took an incision, removed the fibroid from the position, nicely sutured it, and that is how we did the procedure. So as we decided, we did a detorsion, removed the cyst wall fluid, we did a cystectomy, we did a myomectomy, and if you see, the ovarian tissue was now anchored to the posterior surface of the uterus. We see in the first and the second picture, that is where we have fixed the ovary behind, and we attach it to the posterior surface of the uterus to prevent further torsion. And if anyone is planning even for IVF, that is how you can reach the ovary also from the POD. The patient was asymptomatic. There was no hemoperitoneum. Ovary was seen posteriorly on the ultrasound, which we did on the third day, and the patient was discharged. The histological specimen showed out to be benign cystic lesion along with leiomyoma. When we plan for such cases, you have to know that endometrioma is one of the most common form of location in such patients of endometriosis, which is around 20 to 55 patients. And in this also, ovarian torsion cyst is very rare, even if it's case of endometriotic origin. The prevalence can be between 2.5 to 7.4% of gynecological emergencies because torsion does become an emergency. According to a theory by Hutchinson and Brusens, the endometriotic cyst is from either from an endometrial implant in the ovarian fossa or from an inversion or invagination of the ovarian cortex. This cyst can grow into different sizes, can reach even up to around 5 to 6 centimeters. In this case, it induces rotation of the ovary, carrying the cyst around the IP ligament and the uterovarian ligament. So that is how the torsion can happen if the cyst is becoming larger. In addition to the torsion of the endometrioma, rupture of the cyst can occur, hence the interest of cystectomy. It not only improves the post-operative natural pregnancy rates, confirms the histological diagnosis for us, and also improves the response to stimulation. That is why care must be taken that you need to remove the entire cyst wall properly, followed by meticulous coagulation with bipolar electrodes of the hemorrhagic vessels. So you have to remove your cyst wall properly, clean everything inside. Do not leave any debris or any blood clots inside because that itself can lead to again adhesion inside and it will disrupt your tumor ovarian anatomy. However, according to some orders, hysterectomy can have deleterious effects on ovarian reserve, which is marked by a drop in AMH. So it's always wiser to do an AMH before the surgery and after the surgery to have an evidence that yes, your cystectomy was complete, you have not damaged any ovarian tissue, and the AMH remains good even after the surgery. In our case, the cystectomy was necessary on the one hand due to the fact that the torsion had occurred as a complication, and the other hand, in front of a viable ovary, and we had to give the maximum chance of conceiving to this patient later. So that is why we decided that yes, we will go ahead with a cystectomy and not an oophorectomy. And we decided to do an ovariopexy for her because the ovary was viable, because we are dealing with something which was related to fertility. So that is how the plan went ahead. There are other therapeutic options when you think about endometrioma. So you can do an ultrasound guided puncture, but then this is not something which is always recommended because again you leak out the content of the ovary inside the pelvis and that can lead to damaging the structures. You can do ultrasound guided injection of methotrexate or ethanol. These are suggested in books, but I doubt anyone who is doing all these things. Non-invasive therapeutic abstination can be advised in cases where you have endometrioma of less than 3 centimeters. But in our case, we had two issues that yes, we couldn't have done anything because she was planning for a fertility. So thinking about doing a medical management would just take a lot of time and we couldn't wait more for this patient. Plus, luckily, when we went inside and we saw the torsion kind of picture, we could obviously, that required a surgical management. So obviously, we couldn't not operate for this patient. There are risk of other issues which can happen whenever you think about surgery, but that has to be explained to the patient. In cases, all these cases, there are also recommendations that GnRH Alanor can be chosen as a treatment because it helps to curtail the endometriosis spread and reduce the need for recurrent surgeries. So that is what we did in the patient after the entire surgery was done. We gave her 3 months of GnRH so that things were just subsided, things were just better. And immediately after 3 months, we allowed her to conceive. And this was done around 5, 6 months back. And imagine after 3 months, when we started with the cycle, then we stimulated her, she conceived, and currently she is just around 6 weeks pregnant. So, yes, within 2 cycles, she conceived after doing the surgery, and the patient was fine. So, laparoscopic cystectomy or laparoscopic management of endometriosis, followed by a proper judicious awareness about medical management, remains the most indicated thing. So, what you need to understand now, let's understand if a patient comes to you and you have endometriosis and we need to manage such a patient. So, always ask a proper history, understand how many years she's been trying to conceive, whether she's undergone any proper investigations. Investigate both the partners, get an EMH, which is the marker for fertility for a female. Ask for a male female analysis because you need to understand for the female male partner also. Get an ultrasound done. Endometriosis most of the time might not even show in the ultrasound, but when you take a proper history, you'll understand that there are complaints of dyspareunia or pelvic congestion or pelvic pain during periods. So that is how it indicates that yes, this can be there. In different scenarios, you can think about different things. The ultrasound person becomes very important in these cases to manage or highlight the endometriotic aspect when they do the follicular study. You can also opt for an HSG currently if you find that any tubal pathology is involved. But in nowadays, we always think about a histolaparoscopy before jumping into anything else. And a histolaparoscopy will definitely show me this condition. The idea or the concept always is to any surgery, whether it's a fibroid surgery or if it's an ovarian cyst or it's endometriosis, you should always restore the normal tubo ovarian anatomy. that the tube and ovary are in the close proximity and the fimbriae are free. So in such situations, always your surgery should be very well targeted. Don't do any random nicks or cuts or burning here and there. Always use a cold scissor wherever possible. And if any coagulation is required, give short burst of fires in such cases. Try to remove as much endometriotic mass that you can remove, but be careful that you're not doing overdoing things, because that surgery, if you're not very well accustomed to it, you might injure or damage the intestines, the bowels, or the ureter, because that is where the endometriotic mass can also be present. And when you're done with the surgery, give a thorough wash in such patients. That is something which I always do, because you don't need to leave behind any ovarian, any debris, any blood, because those all will coagulate and collect around the tube, around the POD, around the ovarian fossa, and can also lead to adhesion. Also, giving a wash, because CO2 is a cold gas, it might lead to febrile agglutination. That is why it's always wise to give a wash after the surgery, so that that coldness is coming off, so the tubes don't become clumpy. So that is also one of the ideas that we do. After the surgery is done, just check on the with the same telescope, just check around the liver, so that you are ruling out any Fitzgerald-Curtis syndrome which might be hiding in. Always think of tuberculosis in all the cases before you're jumping in any surgery. And once the surgery is done, give a course of 3 months. I would advise give a course of 3 months of GnRH or ovarian suppression, because in that scenario, the ovary just suppresses and you reduce any recent or soon to happen endometriosis. And when that happens, then just immediately plan for either IVF or natural cycle or any form of induction, depending upon what scenario that you're tackling in. In our situation, the ovaries were fine after the surgery. The AMH was good, 3.2. It had been 3.1 after the surgery, so we were good in that patient. At 35, AMH of 3.1 is quite good. There were no other semen analysis issues also, and the tube ovarian anatomy was maintained. We just did a proper induction for this patient, and when in the second cycle, she conceived without requiring anything else, just ovarian induction, and the patient was is currently pregnant with 6 weeks coming under. So that is what that you all need to understand when it comes to managing endometriosis, basic, and fertility at a very basic level. Thank you.
Thank you so much, sir, for this wonderful presentation. We do have some question if you'd like to take that up. Uh, so I hope I'm audible to you.
Yes, you are.
Yeah. So I was saying there was some question if you'd like to take that up.
Sure.
So the first question is, uh, when is the surgery indicate for endometriosis associated infertility?
So at least give it a year of doing natural conception or ovarian induction and ovarian monitoring. But if you find that there is an endometriotic component which is there, it will always hinder with the process of fertility. So if you find that there is an ovarian cyst, or if you find that there is an ovarian mass, it should be planned as soon as possible, because even after the surgery, you will require a couple of months to down regulate things. So if I get a case of endometriosis and fertility, I plan it immediately with them. Wise option, like I have been discussing, always do an AMH before the surgery. Do a CA125 just to have an idea that CA125 is also rises in cases of endometriosis. So after surgery, also you can compare it later to know that your surgery has been performed well, and get your buy your time so that you're doing well. If you feel that the fertility is quite hindered, then think about egg freezing and all those options also in that process.
So there's one last question. Are there any recent advances in regenerative medicine or stem cell therapy for endometriosis related infertility?
Not specifically with endometriosis related infertility, because endometriosis, the plan is see, your AMH is not affected. The stem cell or PRP, whatever we are coming across currently, is not targeted to endometriosis infertility because your ovarian reserve is fine. Eventually, when you think about stem cell, is in cases where your ovarian reserve goes down. So, no, there's no current any target towards stem cell and endometriosis.
Thank you so much, sir, for answering all our questions. That's all from our audience. Before concluding, sir, any take-home
Thank you.
message?
So just take your proper history, be bold when you're doing a surgery, and wise also that you don't overdo things. So you just, when you're managing fertility and endometriosis, be very limited, operate whatever is necessary, don't go overboard, and make sure that your patient conceives sooner whenever you plan for infertility cases, endometriosis. Thank you.
Thank you so much, sir, for joining us today. With your permission, I would like to conclude today's session. Thank you.
Sure.